Yeah, I can see that.
Good.
So for anyone that's just joined, because we didn't get our 10-minute comfort break, I've just given us till 5 past. So 2 more minutes and we'll get started. We were just saying that we were all very impressed with Mark's presentation.
Absolutely.
Lots of unpicking of things to share more, I think, in there and to understand.
Yeah. That whole thing about joint working in an area, you know, that is just so powerful.
Absolutely.
And what he was saying about how quickly they could get something done using that approach in comparison with the kind of the usual way things would be done, which was quite shocking.
Right. We will, just for anyone that is not still on their comfort break, if you want to pop your name and who you are, what your role is in the chat, just so that we know who's here. I'll not go around the group because we've got 20 or so people and we only have 40 minutes. So name and your role in the chat, and I'll start with some introductions. So my name's Anna Gardner. I'm Assistant Director for Health at the Council for Disabled Children. And it's my team that puts this event on. This is our second of the year, and it's we've got lots of workshops. This is one that we're going to focus on. I'll tell you a little bit more about it shortly. Sally, your hand's up, go ahead.
Sorry, it just says the chat has been muted, so I can't type anything in it.
How strange. Can I unmute the chat, I wonder?
I've just got a blank window. It doesn't say anything, only meeting chat. It's just like trying to load.
Someone managed to.
Fabulous, thank you.
Yeah, you got it. I didn't do anything, just so you're aware. That happened all by itself, but I mean, I'll take the credit. So yeah, Deb, do you want to say who you are?
Yeah, so I'm Deb Mclean-Thorne and I'm Senior Programmes Officer, so I work with Anna on health programme and also in the mental health team.
Excellent, and our colleague Jo is also in here listening in. So just a little bit about what we're going to cover. So I don't want to use the word research, although I will actually. I'm going to talk to you about some work that we are still finishing up. So there's a report linked to this work which isn't yet published. So I'm not going to go into the specifics of the area or the people that we got data from yet because it's not published, but as soon as it's published I'll share that so you can read that. So you're getting a sort of sneak peek into some themes and recommendations that we've been working on recently. It's, as I said, it's about a specific region, but actually a lot of what we're going to talk about is informed by some of the other work that we're doing. You've just heard lots of the conversations from a national perspective. We're doing a lot of work at CDC with the NHS England LD and Autism programme, and in fact we've just been successful in being their strategic partner for the children's programme. So a lot of what we are going to talk about comes from the various contracts that we work in. So some of the messages, while they are rooted in data that as I said, we'll share with you in a report when it's finalised and published, I think a lot of the messages are similar from the work that we do in different contracts and at different in different footprints. So the focus of this workshop and the data that we are taking some of these themes from is for that group of children and young people who have learning disabilities and or autism and who experience crisis but aren't meeting the thresholds for admission to Tier 4 CAMHS settings. So they're kind of presenting in crisis across the system in A&E. They might be known to the youth justice sector, they may be in care or on the edge of care. They have a very high level of need, very complicated lives. Often their parent carers are managing, often to breaking point or not managing, and it's often at that crisis point that they become known to the system. So it's that group of children and young people that the research we've done is focused on, and often in the work that we do at a local area level through other contracts, that's the kind of profile, that's the cohort of children and young people that we often have to have really kind of complex facilitated conversations around picking the services and the pathways that group of children and young people follow. So highlights, there is a report, it will be published soon, we'll share that, but we're also putting some of the listed on the slides there. Next slide, please, Deb.
And I was just to say, you may need to put your camera off just in case you start freezing slightly.
Okay, I'll do that now. My connection's not been great, so I will turn that off now. Hopefully that helps. So in the context of our conversation, putting that into context, a lot of which we've already talked about, so I won't go into lots of detail. We're 10 years on from Winterbourne View, so that the scandal that triggered a lot of the work, the Transforming Care programme. So we now have Transforming Care has become the Learning Disability and Autism programme, which has a specific programme, as we've heard, for children and young people, and lots of various work streams and lots of bits of work ongoing. We also know we have multiple models of care. We know what good looks like. We develop lots of case studies at CDC on what that looks like. The Ealing model is one at one end of a spectrum of support. We know there are also lots of other short break type approaches that are for a group of children at the other end of the spectrum. So we know there are lots of things out there that work. What I think we would say at CDC is that we have the components of a system that work, but we don't always have the robust scaffolding around those components that make it a sustainable system or that make it a coherent system. We absolutely have a dedicated and skilled workforce, almost picking their way through that system that doesn't have the scaffold around it to make it a safe and sustainable model. Deb, do you want to move on to the next slide? I'm hoping you can all hear me. I'm not getting any.
No, you can. You can be heard.
Fab.
That's
Am I breaking
fine.
up?
No, you're not breaking up at the moment.
Okay, good.
So yeah, as Anna says, we have, I suppose, little doubt really about what good looks like. Years worth of reports and evidence that are telling us very similar things. So I won't kind of exhaustively read through that list, and it certainly isn't an exhaustive list at all. But I might just say that is underpinned really by, I guess, an agreed children and young people's mental health service and learning disability approach, which is focused on prevention and early intervention, and which involves schools. So you'll see very much that kind of focus on the word early links with education services, early warning system, potentially linked to a key worker, and also an effective and truly multi-agency dynamic support database in there. And that's something that I think we spent quite a bit of focus on in some of the work that we were doing, you know, how that could be as multi-agency as possible and truly dynamic as well, as a database, which made it more effective. So I won't be exhaustive on all of that. I think there's such a lot of work that's saying, what does good look like? So in our work that we've done, and certainly in the kind of report that Anna mentioned that isn't published yet, I suppose we could say that the themes that we identified were around like these three categories really. And they are kind of around provision, processes, and people. And provision, very much as you can see there, it's about, is there enough of it? Is there a range of it? And the creativity and flexibility of kind of what can be provided. And particularly in that, I guess it's saying a range of provision that includes pre-diagnosis support, family support very much for parents, which is focused on supporting their emotional well-being. And things like the creativity around using, for example, a personal budget offer, that can support rapid and flexible access to more personalised support. And then perhaps an offer that can be accessed without assessment at a lower level of need. In terms of region-wide focus, again, that's something, a region-wide review of perhaps joint commissioning arrangements in particular areas. And then the next category around processes. Again, as I said, dynamic support databases, a lot of work around what could be more multi-agency use of those, making sure that they are live and dynamic documents, and kind of confidence and reassurance that for the lead professional, so that they know what they can explain the purpose of the dynamic support database and how it's going to support the families and the children and young people on it, and a shared definition and understanding of risk in relation to the inclusion on that database. And then finally, around people, I guess, ultimately, a consideration about where universal workforce needs should be commissioned in that integrated care system or regional level. And teachers not only need to understand autism, they also need to understand how to appropriately raise concerns. So I'll move on to the next slide, and we can talk in a little bit more detail. Over to you, Anna, about that category of provision.
Thanks, Deb. So yeah, as Deb just talked through those three themes, those were the kind of the data that we got from the bit of work that we did in that specific region. It was very chewy. There was a lot of crossover, and lots of the messages we got from the people we spoke to, commissioners and some families as well, and strategic leaders. There was a lot of crossover and interrelated messages, which is often what we find in SEND. Nothing is standalone. But we did, on analysing that data, we managed to put it into those three Ps, if you like, so provision, processes and people. So we'll just unpick, I suppose, the risks that we highlighted within each of those themes and some of the recommendations that we make. So unsurprisingly, provision was a very common thing to come up in the conversations we had with commissioners, with families. Essentially, that there wasn't enough of it. You won't be surprised. So I don't want to tell you, we could have, before doing any of the research, we imagined that might be what came through. But what was really clear was that there wasn't a spectrum of provision, I suppose, to meet need at all levels. There was a big gap in terms of the kind of most complex end, in thinking about children and young people who maybe go to residential special school, that what was there for them locally that didn't exist, but also at the a more universal end in terms of short breaks, there was a real gap. We took an approach through analysing the data. I think one of the things that came up, one of the questions that struck us as we were analysing the data was risk was a frequently came up. So how can we manage risk appropriately and proportionately? The aim of the Transforming Care programme, which is now the Children and Young People's Learning Disability and Autism programme, is about keeping children and young people at home or as close to home as possible. And risk was the one thing that kept coming up in the conversations we had that prevented people from supporting children and young people to be at home or as close to home as possible. So with that kind of risk lens, we came up with these key risks under provision. So we know that there's a lack of early intervention provision, so that initial bit of provision as needs emerge or as needs start to escalate, and there's not a bit of provision to meet those needs generally, and the consequence of not getting that right, unsurprisingly, is that needs escalate and the needs get greater over time. There was also a real clear theme and sense from the families that we spoke to, but we actually heard this from the commissioners too, that there's a real lack of family support. And unsurprisingly, the consequence of that lack of support is that families' ability to care and to keep their children with them at home and in a safe way, their family's ability to care is not safeguarded. We're not protecting that ability to care. And thinking about the lack of provision for the children at the most complex end of that spectrum, and what does that look like? Deb listed a whole range of things that we know work from the review that Christine Lenahan did a few years ago, but from multiple other reports too, where there's that lack of provision for children at the most complex end. That's where we get this kind of inevitable cycling that I suppose triggered the region that asked us to do this research in the first place, but it's that inevitable cycling between inappropriate provision, the provision that's available and trying to make what's available fit needs and meet needs, and the request for tier 4 provision, whether or not that is appropriate. So these were some real key themes coming out from the conversations we had. Next slide, please, Deb. So in terms of what we, based on the data, we looked at what we could really clearly see was needed. Again, nothing surprising, but I think what always felt reassuring in analysing this data is that a lot of the national policy, national initiatives, there was a real triangulation between what we were seeing as a problem and the things that are being put in place to solve some of the system issues. So a lot of the chat this afternoon, I think, says that we know the issues, we know what they are, they haven't changed. But I do think there are lots of opportunities at the moment. We're in a real kind of perfect storm of opportunity and new policy initiatives. So what we know is that diagnosis and support is often hard fought for. A lot coming through the data that we got around identification of girls with autism. So lots about girls having unmet needs and needs escalating amongst girls. We also know that short breaks and respite, that spectrum of support I mentioned. So there were many areas we spoke to that had a really good crisis offer. But also there was a lot of recognition that sufficient specialist providers for this type of provision don't necessarily exist, or that's where we start getting into the area, the arena where children and young people are being sent far from home. We did see some really innovative approaches to fostering and foster carers to provide some of those short breaks and respite. So we did see some really good practice. It also helped us to see what the gaps were and where we should be focusing our investment efforts. A lot of learning to be had. I'm sure lots of you will know about the Ealing model, which is a really innovative and now very well established model in Ealing, unsurprisingly, to support children and young people at that most complex end. And I know lots of other areas are now looking to develop their own versions of that. So it's about a model that seeks to address challenges at local level by providing respite or kind of outreach support and prevent those crisis admissions and family breakdowns that, as we said at the start, we see so much with this cohort. Again, no surprise, but one of the things that came up as being needed and where there was good practice, it was showing that it works. That personal budget offer that's flexible and responsive. A lot of people we spoke to, commissioners are doing lots of work around personal budgets. I think from a family perspective, the families we spoke to felt that a personal budget that was about something continuous and routine was positive, but at crisis point or in the run up to a crisis, actually personal budget offers weren't flexible and responsive enough to meet those needs. So if we can break down some of the mechanical barriers to making personal budgets more flexible, then actually that would be a really good way of supporting this cohort of children and young people to stay at home. The families we spoke to talked a lot about the family support not being sufficiently personalised to their needs. We know there are lots of off-the-shelf offers of family support, family interventions, but we know those don't really work for those with the most complex needs, and certainly not at crisis points. So some more innovation around what family support looks like. We did, and when we publish the report, you'll see that there are some examples of an offer that is a bit more responsive and personalised. So we know things out there exist, and we'll do our best at CDC to find those and highlight them and kind of showcase how that happens. And there was often a conversation again amongst parent carers, but also the commissioners and the practitioners working with them, that actually this group of parent carers needed some support for their own well-being as well, particularly at crisis points. So there was a gap around that specific parent carer support provision to focus on their own well-being. Thanks, Deb.
So really that's just a summary of the second P in the kind of 3 Ps that we kind of summed up, I suppose, those conclusions in around processes. And this slide really just gives you a bit of a visual representation of the risks in that category and the consequences of not getting it right. So very much, as I said before, a lot of the focus about how as a tool, the DSD is used, the dynamic support database is used, and sort of very much a central risk in that around if there's lack of multi-agency input to the DSD. And the consequence very much being, obviously, there's just not enough granular understanding about that child's risk profile and therefore missed opportunities. And a lack of cross-agency understanding about what its purpose is means, again, professionals missing that opportunity to put children forward for the DSE, and then the consequence of that, I guess, is those children and young people reaching crisis. So just to kind of unpick that a little bit more, I mean, key in that, obviously, the multi-agency input embedded across all the agencies so that all types of children can get included on that tool, and a strategic direction within councils, education services and others. The sensitivity, I guess, of the tool, the DSD, is vital because agencies can have a different understanding of what risks need to be flagged, and then there could be a failure to include intelligence that could be fundamental to really good assessment and accurate assessment of that child's level of crisis, and an in-depth understanding of the child's needs and circumstances, and broader focus, including the risk of involvement in, for example, criminal activity, or input from the youth justice sector and other adverse events, and the resulting poor outcomes that could then occur. There are additional factors, and I think kind of Anna touched on this a bit in terms of this is about how lots of those areas are very much overlapping, but additional risk factors to consider in relation to the DSD. Obviously, age was a really big factor in the sample that we were looking at for the study we did. All the young people were aged between 15 and 16 at the time of crisis, and others that we considered as part of that sample were in the same age range as well. And so you can really see there that, you know, families might comment that they would be coping well until puberty hits, and that therefore, you know, perhaps that age is a significant marker to maybe warrant a kind of an automatic review, perhaps, of any child on the DSD on their 15th birthday, perhaps, or at the very least take a proactive approach to the family and ensure that they're confident that the young person is not in need of review. School refusal, attendance exclusions, very much something cited as potential risk factors that are not to be underestimated and could be given more focus on the DSD, and also the resilience of the family, kind of all factors in place for that family resilience in terms of managing their child's needs and potential crises. I mean, in terms of the informed decision making, again, that shared definition of risk is key, and I was very much thinking about that kind of tendency to, and that was captured very much, I think, in Mark's slide in the last presentation, about that kind of very divided thinking from different areas of work, as if a sort of child is in different component parts. And I thought that was really quite powerful in terms of their people being on the same page in terms of their interpretation, understanding. And the same in relation to agreeing admission. So, you know, there being clarity or agreement about what type of symptoms or level of risk necessitates an admission is really crucial, and could be the subject of a lot of sensitivity. And so do the systems actually support professionals in reaching that agreement? And perhaps there's tension often in determining whether or not a young person with a learning disability and autism is having a mental health crisis or is experiencing emotional dysregulation. So again, that presents another tension potentially within the system and within the process for considering admissions. So over to that final P, Hannah.
Thank you.
People.
Yeah, so in keeping with the P's, we went with people and what we mean by that is workforce skills, expertise and understanding. So from the conversations we had, workforce development or workforce gaps, I guess, were a real key feature. And I know that came up in the conversation this morning in our plenary chat around workforce, and there was quite a lot on the chat around recruiting to specialist posts, you know, the money being there for the post, but the people not being there to apply. So I think workforce was a really key one that we wanted to unpick a bit more. So sticking with the risk focus, the risks that we identified from this specific bit of data that we were looking at, there was a lot around a lack of training or support for those working in mainstream schools to work effectively and manage needs around autism and learning disability, autism particularly. Obviously could lead to a potential escalation in needs there and needs not being met appropriately. So a big focus on mainstream schools. And the second workforce issue, I suppose, or risk that came out of our analysis was that lack of agreement or understanding about a solution for a child's needs. So the sort of tension, I guess, between community-based support and the provision that is needed to keep that child in the community and meet their needs safely and effectively versus, I suppose, a crisis or an escalation need, suggesting that actually residential and inpatient admission is needed, and often that wouldn't happen. But what does that mean? That means we've got that continual children cycling around the system, community professionals feel across agencies, from health, education, care, feeling that they're left holding levels of risk that they're with which are uncomfortable. So risk, a really clear feature again of the people data, if you like. But I will unpick that a little bit more now. So as I said, mainstream education was a big focus of our conversations from professionals and with parents and families. So a few questions, I guess, that our data raised, and I guess some of the recommendations that we make chime with things that are in the autism strategy. So I will think about that in a second. But a question that came to us was, is autism awareness in a mainstream education setting sufficient? Do we feel that we are equipping our education colleagues sufficiently to understand needs and to meet them within, as best they can within the resources available to them, and also thinking about their ability to support when needs escalate, not necessarily holding and meeting those needs in their setting, but understanding at what point to seek further support and where to seek that support from. So some kind of key questions, particularly for this region, but I think the messages would apply across the country around mainstream education and their particular understanding around autism. I know we've got other workshops happening this afternoon around some really innovative projects looking at upskilling education colleagues and parents working in schools to do that. So lots of work out there, but I think it felt like a real key feature of the conversations we were having. The sort of wider workforce skills gaps, it comes back to this sort of risk management and professionals feeling that they were often holding risk or making decisions about risk assessments that they didn't feel sufficiently equipped to do. And also something around the universal workforce autism awareness. And again, I know there's lots of the Oliver McGowan training is happening in inpatient settings. So there are lots of things happening out there, lots of opportunities to do that upskilling. And one of the recommendations we'll make on the back of this report is that all of those opportunities are drawn down and utilised, and that people know what's out there. Because as I said, there's a dearth of stuff. It's just possibly all coming down towards people from the wrong places or not being explained clearly. So some clear gaps, but I think lots of things in place to help meet and support and plug those gaps. A slightly chewier one that I'll talk about now, but I think it could be a whole 40-minute conversation in and of itself. It was the workforce skills and competence around dual diagnosis and understanding where mental health needs arise in those with autism or learning disability. And there were some really good examples of kind of peer-to-peer support, providing a forum to discuss individual cases where there was an additional complexity, and bringing skills from a variety of agencies and professionals around the table to talk about individual cases and to support, with the idea being that it was supporting the lead professionals or the main professionals working at an individual level to keep that individual at home, close to home, and supported them well. And so it's really about supporting. It's about support to hold and manage risk in the absence of specialist intervention, if that isn't available or doesn't apply. And the final point here around workforce is from a commissioning perspective. And we mainly spoke to commissioners. We did speak to some frontline practitioners, but it was a lot of commissioners. And I think a real question is, do our commissioners who are working in this space, do they have sufficient capacity? And I think the answer is probably no, but do they have sufficient capacity to hold this complex agenda in their already wide portfolios? And as we think about the new health systems architecture, as Sue North explained, and we might be making our commissioning portfolios even bigger and broader and have bigger footprints, are we really supporting our commissioners to be upskilled to commission well in this space? And actually, we talk about a lot about investment in frontline training. Are we sufficiently investing in our commissioners and helping them develop their commissioning skills in a very specialist cohort? So a lot of conversations through this bit of work around that. And on that note, I think if you could just move on to the next slide, Deb, which I know we've heard from David today, who talked about the National Autism Strategy, but he talked more from an education perspective. There are a few things in there that I guess brought us some reassurance as we were writing or doing this data analysis and writing recommendations about the things that might be in place to support some of these challenges. So there are lots of related recommendations in there. If you've not already looked at, I'm sure lots of you have. But there's a lot in there about the identification about speeding up identification for autistic children and young people who are on waiting lists. So there's a lot of money there. There is also there's £7 million to test and implement the most effective ways to reduce those waiting times. And there's also a lot of really interesting research just now looking at different pathways around autism diagnosis. We can share the links in the chat afterwards. But I think that felt like it was supportive of the things that we were finding, and possibly supportive opportunities to meet some of the challenges that were raised. There's also £3 million announced in that National Autism Strategy. And as David said, they do go into almost KPI level detail about how that money is rolled out and how it can be drawn down. So that's £3 million to support post-COVID respite and short breaks. Again, with that same aim of reducing admissions of autistic children and young people with or without a learning disability into Tier 4. The £600,000 that David also mentioned for autism training. So at the moment, that's the Autism Education Trust. But there's also the work in the Northeast around autism in schools. So lots of opportunities there to do some of that upskilling in mainstream education around autism that our research certainly highlighted was a challenge. And the final point from the autism strategy that I wanted to make talks to the Bourne and Bradford work that we just amazingly heard Mark talk about. So I won't go into more detail than that, but lots of work to understand how that can be replicated in other footprints.
Okay, I feel that we have taken up so much time, Anna. I'm going to just stop sharing my screen.
So frustrating we can't send you the link to that report, but I promise you will get it in due course. It's just in its final stages of being signed off, but that data and recommendations will all be in there. So any thoughts? I'm just looking back through the chat, see if we've got any questions. And a hand up, is that Alison? Go ahead.
It's Hammersmith and Fulham. I'm accompanied by my cat. Sorry.
Oh,
is
excellent.
Joining us, and I've got 2 laptops on the go because I'm badly multitasking. A really interesting discussion. I think the thing about how well owned and understood the DSD is in a local area is really, really pivotal. And we've certainly seen I think ours has really gone from strength to strength with that multi-agency, not just attendance, but really ownership. So we have our lead EP from around ASD, obviously CAMHS services, forensic CAMHS, positive behaviour support services, strong links with our YOS, our care leaving sort of teams. So it feels a slight cast of thousands, and obviously not everyone's needed for each young person, but that problem solving and thinking, even if children aren't on their sort of known to their service, is sort of really helpful. And we've actually got a parallel list. So I think we include young people who are highly suspected of having autism, so on the diagnostic pathway but not yet assessed, because we don't feel it's fair to penalise them because of a delay in diagnosis from having that support. But the clinical team have to be fairly confident that the young person is going to end up with a diagnosis. And we also offer that support. We're one of the pilots of the ASDLD key worker sort of team, but ours has been so successful that we've actually run a parallel sort of tab on our database that's for children who haven't got ASD or LD but have got escalating mental health needs, where actually that same DSD type approach is required. And that really came from a sort of request from the professional network, where people were wanting to refer to children who didn't have autism, but because it's such a great opportunity with those you know, professionals sort of together in a room. But I think it is about that multi-agency investment in it, and it's certainly seen as a core part of our escalation processes locally. So I just wanted to say that
I think that's exactly that's exactly the approach that we would advocate for this. I mean, this region obviously has multiple local areas within it, but a bit of consistency across local areas. And there was that, I think, was I think I've frozen again. I think
we can hear you.
That
we can hear you,
Anna. Okay, good. So yeah, excellent, Alison. And we may I might well be in touch, because I think we need to write up those examples of I suppose broadening that approach and making use of the professionals and the expertise that you have around the table, because like I said at the start, SEND is never discrete, is it? And it's about the interrelated, interconnected needs. Any other hands up or questions? I know you all have a second workshop to go to, so we will let you have time to virtually run between.
I think, is there a question in here from Victoria?
Oh, and I can see Natasha's hand up. Natasha, go ahead.
Thanks very much, yeah. This is really interesting. So I suppose I was interested to sort of think about what are the agreed risk factors, and is that something that's contained in your report?
Yeah, I mean the risk. So age and gender, gender particularly, I think was one, and also, as Deb explained, that sort of the transition. Well, I suppose that's age, isn't it? But one of the things.
Yeah.
Sorry, Deb, go on.
And school refusals, attendance and exclusions.
Okay, so as you outlined there, and then just another comment really is sort of in terms of what you said and in terms of what Alison has said. I was just having a conversation with the commissioner in my previous borough about the adult autism DSR that they've set up, and she said that she really feels it's of all the DSRs that they have in the borough, it's the most successful one, because you know, there is an adult LD team and they've already got a forum to have conversations, whereas there isn't an adult autism team as such. And so, you know, I think Alison used that word in terms of owning the DSR, and the commissioner was saying they all own that space. It's, you know, and so therefore there's really good engagement. And I think that that's quite key in terms of an effective DSR.
I just thank you, Natasha. That's really helpful. I see Victoria's comments. So the first question was, how do we get around repeated detentions under Section 2 of the Mental Health Act, and to expand what is being done with? Oh, and that's an acronym that's I'm not sure of. So Victoria, is that I don't know, AMHP, to help them identify improper use of the Mental Health Act. I mean, I think that to me that speaks to training and understanding of how approved mental health practitioners. Thanks. I suppose that speaks to training. What is worth noting is that the Mental Health Act, don't worry, but apologising, the Mental Health Act reform, and I'm going to have to I'm going to not say the wrong thing now, but I'm going to pop in the chat once we're all away what it does. But there's something in the new in the Mental Health Act review that talks about autism, and so I'm going to find the exact wording so that I say the right thing. But hopefully, Victoria, that might go some way to addressing what you're asking. You'll also have access to the chat once we sign off, so you'll see it in there. And you now have 7 minutes before your next workshop starts, so I will absolutely let you go because you only got a couple of minutes of a break at the start, but thank you all for joining. There is an evaluation form which you'll get a link to in your next workshop, so please do fill that in, because as Amanda said, we need to report back to DFE, either what worked for you, what didn't work, suggestions for future sessions too, also really helpful. And lovely to see you all, lots of names that we recognise. Sorry, my camera is off and signal a little glitchy, but hopefully it was not too disturbed for you all. Take care, everyone.
Thank you very much.
Everyone.
Bye.
Bye.